clinical tuberculosis in today's context. I think it's my view that the success of the standard WHO DOTS program has taken care of the easy cases, and it's enabled us to focus on current issues that complicate TB care and control, particularly drug resistance and comorbidities, particularly HIV infection, but also risk factors. And not all of these issues can be addressed fully with TB control programs. They require increasing reliance on primary and specialty care outside of the TB control program. And also, many of the risk factors that I'll be mentioning can't really be addressed by the health sector alone, but require a multi-sectoral approach. Let me present a case of a woman that I took care of in the intensive care unit at San Francisco General Hospital about 2 years ago now. This was a 76-year-old, previously functional Chinese woman who'd been in the US for 8 years, was admitted to the hospital because of declining mental status for 2 weeks. Her past medical history was pertinent for hypertension and rheumatoid arthritis. She was started on, I never can pronounce this right, adalimumab, a TNF-alpha inhibitor, and methotrexate in May. She was tested with a quantiferon test to identify whether or not she had latent tuberculosis infection prior to starting treatment. When she came to our unit, she was febrile, hypotensive, had a pulse ox of 94% on oxygen. She was poorly responsive, had a supple neck, a left supraclavicular node, atrial fibrillation, bilateral wheezing, some abdominal distension, and a non-focal neurological exam. Her initial lab values showed that she was slightly anemic with a hemoglobin of 7.8, a white count of 14.4 with the left shift, thrombocytopenia at 81, and mild metabolic abnormalities, including a bicarb of 21. Her creatinine was 3.14, and her initial arterial blood gas showed a pH of 7.45, PCO2 34, pH, PO2 of 88, with on 6 liters per minute, and a lactate of 2.8. So she was in mild shock at this point. This was her initial chest film. You can see diffuse bilateral abnormalities more prominent at the bases. CT scan showed scattered nodular densities, as well as a moderate-sized right pleural effusion. Our working diagnosis was that she had sepsis, probably bacterial, but fungus was in the differential because of being on the immunomodulators, the TNF-alpha inhibitor. She started on broad antibiotic coverage, given fluids, required vasopressors, developed acute respiratory failure that required mechanical ventilation. She promptly developed a tension pneumothorax requiring a chest tube, had worsened renal function with a metabolic acidosis, required renal replacement therapy. Her platelet count nadired at about 20,000. All her blood cultures were negative. And on day 3, she had a sputum AFB stain that was positive for AFB, for mycobacteria. And the organisms are also seen in acidic fluid, but not in pleural fluid or CSF. She was started on 3 drugs that could be given parenterally: isoniazid, rifampicin, and levofloxacin, plus 2 oral agents, PZA and ethambutol. She also had a sputum fungal culture that was positive for aspergillus and was started on antifungals, and she died 2 weeks after admission. This was her final chest film. The point here is that this is an increasingly common scenario, both in the US and in many parts of the world, where patients are being treated with immune modulators, corticosteroids, other immunosuppressive drugs, as well as TNF inhibitors being used widely for inflammatory bowel disease, psoriasis, and in her case, rheumatoid arthritis. And this shows the frequency with which various opportunistic pathogens occur in patients starting on TNF alpha inhibitors, with tuberculosis being one of the three most common of the opportunistic infections. So we need to begin to be thinking about tuberculosis in a different sort of context, as a complicating factor in persons who have disease that is either the cause of immunosuppression, such as HIV infection, or are given treatments that result in immunosuppression, such as corticosteroids or TNF alpha inhibitors. This begins to look at other risk factors. This is an analysis done by the group at WHO a few years back, where they calculated the population attributable fraction of tuberculosis that could be blamed on these factors that are indicated on the left-hand side of this slide: HIV infection, malnutrition, diabetes, alcohol use, active smoking, and indoor air pollution. And you can see there that there are substantial population attributable fractions to each of these. This column adds up to more than 100% because there is some overlap in these different risk factors. So this makes the point that there are a number of very commonly encountered risks that can increase the risk of tuberculosis quite substantially. I'll focus on a couple of these. So we will pause here briefly and then come back to talk more about these risk factors.